Hello, welcome again to our little emergency podcast series on Triage Not File Service YouTube channel. Today's topic is going to be triage, and the main reason why we want to talk about it is because although it's a very simple approach to patient assessment, often is misinterpreted in how it's performed and what is the ultimate aim. So I just wanted to summarize what are the most important aspects to always keep in mind related to triaging a patient and what concerns you want to deal with when you are assessing a patient via a triage evaluation. The triage is a standardized approach to patients that presents to the emergency room. And no matter how fancy the emergency room is, the patients that arrive through it often are either a patient that is sent over to the emergency room because the referring doctor could not further evaluate or stabilize the animal or treat the animal, or they are patients that come in on their own. They are the classic walk-in patients. Independently from that, they deserve a triage exam. They require a triage exam because the information with which they come can be largely unreliable at defining the severity upfront of what you'll be dealing with once they arrive. So let's see a little example of a hit by car patient. So there's a classical trauma patient that would present to the ER, but as I said, this is just an example because a vomiting and diarrhea patient or a respiratory distress patient would be approached exactly with the same means that the hit by car patient can be assessed. Here we're going to see a little video that in a little bit of a vignette can give a couple of hints of what happens during the triage and the timing of it. So now I'm going to be quiet during the video and enjoy.
Thunder Muffin è stato investito. Oh, my dog got hit by a car! Cheer! I see an emergency. Please put the dog on the gurney.
Let me listen to your heart really quick. Take him back.
Ottima idea. Portano via. What we got?
Hey doc, he's pretty shocky, tachycardic, dyspneic, bleeding from his mouth a little bit.
Alright. Let's put him on his side and do a quick assessment. Thunder Muffin è collassato. Devi fare qualcosa alla svelta.
Hey Doc, what would you like to do next?
Nel frattempo, DN va a parlare col proprietario.
Hi sir, so sorry to keep you waiting. The doctor is assessing Thunder Muffin right now. Can I get a more thorough history to find out if there's anything we're missing?
Yeah, sure.
Okay, don't be upset, I'm so sorry. Alright, can I get you a glass of water while you're waiting?
Please.
Okay.
Alright, well, this is a little video that I put together to give an idea of what is the approach to the trauma patients or the emergency patients that arrive to the hospital. As you saw, the initial evaluation that the student did when the reception notified us of the arrival of a patient was a very, very brief assessment. She assessed basically mentation, and she ausculted the heart, felt the pulse, evaluated respiration, and based on those findings, she determined that patient wasn't stable. That's what the triage is about. It's a very, very brief assessment. It's a minimally invasive approach to recognize the stability of the patients, where although you can define whether it is stable or unstable in some circumstances, when the triage exam leaves you in doubt, you will always err on the side of caution and recognize that patient as possibly unstable, which means that if you say, I don't know, that means that patient should be considered a possibly unstable one and require a little bit of more of a complete examination of the major body systems. So we're going to go through the aspects of the triage and the major body systems assessment. So the triage, when you are approaching the ER medicine, is definitely the first step to standardize in a way that the admissions of patients is formalized in an environment where chaos normally prevails, because patients don't come on appointment, patients don't come at the time that they are expected, patients come all at the same time, or they don't come in at all for the whole day. But given this unexpected trend and flow of patients, it's very important to have standardized the way they are received. So for that matter, it's very important to set the priorities of care for the patients not on arrival order, but based on the severity of their condition and the stability of their clinical picture. If those are affected, then they will have to be prioritized over even the patient that has arrived 2 hours ago or 2 hours before, but still doesn't show signs of any instability of his clinical condition, nor a problem that is considered a high priority, meaning putting him at risk of sudden deterioration of his clinical condition. The other important aspect during triage that is extremely important is having resource allocation. A resource allocation means being fully aware of what resources we have available in the triage unit in terms of people available to help, should we need them available, and resources in terms of monitoring, supplies, and procedural equipment that we may require and know exactly where it is. That starts from the clippers, make sure that they are available and they cut and the blade is clean, to the IV catheter sets, knowing which drawers they are and with the tape and everything else ready, flushes ready, know where IV fluids are and the infusion lines are. That's what the resource allocation is about, and make sure that the room is always ready to receive patients, no matter how high or low the patient's flow is. Obviously, once again, and this is a priority that is very also important to communicate to the clients in the ER service and receiving room, the sickest patients are always treated first, no matter what the order of arrival is. The codes of patients also is helpful to use in a busy ER service, because allow us to track those patients. The most simple version of this tracking is the recognition of the triage status of that patient, where the patient is either in urgency of care, so he's an unstable patient, versus is a stable patient that has to be seen as soon as possible, but not necessarily prevailing in prioritization over the ones that arrived before. So that is the simplest version. The more advanced and more articulated version goes from the patient that is at risk of death or he already requires CPR, to the emergent patient that is an urgent threat of life, to the patient that could become a threat of life but certainly will have to wait over the one that is nearly dead or already in need of CPR or resuscitation. And then the classes that are less relevant in terms of urgency. Remember that for the standpoint of what is an emergency, the definition of emergency depends on who declares such emergency. I give you a silly example. For my grandmother, her cat's 17-year-old cat that vomited once is a serious emergency. But also the cat that climbed the tree for my grandmother is a serious emergency that warrants calling the cops and getting a 2,000 franc bill when they came out to get the cat off the tree. So you understand that emergency is not a matter of urgency of care required by that patient, but simply is a definition by who decides whether there is an emergency or not. The role that we have in the waiting room is to define whether that emergency recognized by the owner is urgent versus not. The urgency of care is the one that then allows to decide whether that patient needs to be prioritized in his care over the others. And obviously the one that are less urgent, let's say the puppy that arrives with a radial ulnar fracture because he jumped off the car and now was limping, is certainly a less urgent patient. Is not at risk of life, is extremely unlikely to have a deterioration of his condition that is going to put him at risk of life, is certainly not anything that you're going to just send home because it's a relevant injury that you want to assess, but you will not be certainly prioritized over a cat in respiratory distress, or a cat with urethral obstruction, or a dog that was hit by a car, or any of those urgencies that certainly have a compromise of a major body system beyond a simple fracture. And then there's the absolutely not urgent patient. The patient that comes into the ER because the owner at 2 o'clock in the morning found a tick on his head. And that is the patient that will also come as an emergency, and he will have to be addressed with a triage exam, and the client will have to be notified that because there are a number of urgent patients at risk of life and with injuries that require care, the tick on the head of their dog can easily wait until the morning to see their veterinarian, but if they really desire us to take care of it, the wait will definitely take as long as no more urgent patient will be in the waiting room. That communication is extremely important because for that owner, the tick on the head of their dog is an extremely severe emergency that is worth the money of coming at 2 o'clock in the morning and have a doctor assessing that tick and removing it. That will not change in his mind. Our responsibility as triaging doctor and emergency doctor is communicate that such emergency in his mind has no urgency of care for their dog, is important to us just like anybody else, but obviously any patient that had arrived or will arrive with urgency or care will take his spot to be assessed first. Once again, ER medicine and emergency medicine, not found medicine, lives around the theory of chaos. Chaos doesn't mean random. Chaos doesn't mean to be disorganized. Chaos means that the motions of patient flow, resources available, and procedures that are happening change constantly over time. Doesn't mean that they don't need to follow rules of engagement and rules of application. So being organized in the approach even to the most chaotic system, which is in medicine, emergency medicine, allows you to dare farther than you believe. Because one of the simple misunderstandings that we have is confusing emergency medicine with urgent care. The urgent care is where everybody goes with their little thing and like a little wound, a simple sneezing, a stuffed nose. That has nothing to do with emergency medicine. Emergency medicine includes the dying patient that arrives hit by a car and needs to be stabilized. That's not what urgent care is in the human side. The ER is the not fault where, yes, you're going to see the urgent care patients with simple injuries or the taken head, but you're going to have the critically unstable DKA dog or the unable to urinate cat for the past 24 hours versus the dead on arrival hit by car patients or the dying hypovolemic hemoabdomen dog. That has nothing to do with a simple urgent care, which is what it is in human medicine, but is what it is emergency medicine. In those situations, you need to dare to do things that are life-saving. To be able to do that requires discipline and an organized approach. The one that you see on this slide is a really good book that I highly recommend you all to read, which is the Checklist Manifesto. That has been proven, has been written by a doctor and also an author, but has been applied in many systems, including surgery, anesthesia room, intensive care units, and ER services, to kind of standardize an approach to patient care, to even just the simple steps for the placement of an IV catheter to any other procedure that is being performed. So the first step, as I said, on the being organized is having an organized room. And room preparation is always an ongoing process. It's nothing that is done once and remains the same. So the responsibility of the ER team, led by normally the TPA, is maintaining the room in a functional state, meaning things are charged and working, drawers are full and ready, blankets are available, tape is available, the clippers are cutting, the lights are working, the oxygen is running, the suction has connected the vase for the collection, IV fluids are hanging, squeezing bag are ready, syringes are available, and so on. The crash cart is ready with the emergency drugs, sticky pads for ECG are ready, the blood pressure monitors are available, and so on, to make sure that the entire room is ready and fit to accommodate an emergency coming. The emergency room needs to be tidy. The emergency room, not because works around confusion and critical situation, needs to be a mess. The cleaner the room in terms of how organized and simplified things are put in drawers and accessible they are, the better the function of the room. Here you see a really good example of a very well cleaned but very busy emergency room. This room receives an average of 50 patients a day. Despite that, in every moment possible, this room is put in the state that you see in this picture. Extremely functional, extremely taken care, well organized, and restocked. What are we aiming for during the triage exam? So the first question that you can never forget when you do a triage exam is, does the animal have an immediately life-threatening problem? If the answer is yes, what is that life-threatening problem? And the next aim of the triage exam is, how quickly does this animal need an intervention? Those two questions are the most relevant to be able to answer during your triage examination. So how do you do the triage physically? The first step is, how long should that take for the patients that arrive to the emergency room to be receiving a triage examination? The answer is less than 1 minute. In my mind, less than 30 seconds would be ideal, but I accommodate the 1 minute just because I'm a lenient person. What do you want to know during the communication that you have when you arrive? Because we are not robot that we walk there and we touch a patient. Here we hear the bell of a patient that arrived, and here it goes, our first ER doctor going out, and we are at 10, 11, 12, 13, 15, 14, 16, 17, 18, 20. Yep, in 20 seconds we are triaging the patient. That's good. Anyway, going back to the lecture. So what do you ask the client? The brief reason why the patient is presented: he's not breathing well, got hit by a car, I think he had a seizure, I think he ate a pound of marijuana. Whatever is the presenting complaint, that's the only question that is relevant in that state. And then the triage assessment. The triage assessment is the most simplified approach to physical examination. The most important parts are circulation, breathing, and neurological status. Those are the three things. If you want to think in organs: brain, heart, lungs. Those are the most important things. And each of them has a little bit of a folder of things that you're going to assess when you want to determine whether those systems are affected to the extent of considering the patient unstable. And we'll go over them one by one. On top of that, in dogs and cats, there are situations where maybe the cardiovascular status is okay, the breathing is not affected, neurologically they are not severely compromised or not compromised at all, but still the reason why they came is certainly considered a potentially life-threatening emergency. A classic example is the block cat with the urethral obstruction. That animal is a patient that requires immediate attention, but it may not be recognized by assessment of the cardiovascular stability, respiratory status, and neurological assessment. So palpating the bladder in a cat could be helpful to determine if that patient is a red, so unstable case, or not. Same case for a GDV dog. A dog arrives with retching and distended abdomen, could be a dilation, gastric dilation volvulus. Maybe cardiovascularly stable, but you can decompensate any minute. So recognize that is a dog, is a large breed dog with a distended abdomen, is part of a triage exam. Bleeding, obviously, is another important thing to evaluate because the patient might not be compromised by the bleeding, but if he has an ongoing severe bleeding, you want to know if it's present, and it's obvious, and if it's there, know what it is. Once you have done triage, as I said, the simplest version of the recognition of what triage class that patient belongs to is stable, unstable, I don't know. And the I don't know automatically become potentially unstable, so is requiring further immediate assessment that then may allow us to put it in a class of stable, but still, as I said, in a doubt on not knowing if stable or not, is going to be treated as a possibly unstable one. The more articulated version is dividing in a minimum of 4 categories, where category 1 is a patient that will die without an immediate intervention. That patient will have top priority in assessment, top priority in care, top priority in stabilization. The category 2 is a patient that is critical and needs urgent attention within minutes from arrival, but is not in an immediate risk of death. The class 3 is a sick patient that certainly would need help as soon as possible, and the class 4 is not truly an urgency. It might be an emergency for the owner, but as I said, if that tick on the head of that dog stays on for an extra 24 hours, unlikely is going to change the outcome for that patient. As I said, once you've done that initial triage, the triage itself expands into a better assessment of heart, lungs, and brain. So it can be completed by someone else is working on stabilizing or doing initial procedure for the patient, such as an IV catheter or running blood work. You say, okay, this patient is unstable. Then I do a better assessment of the heart, the lungs, the brain, because as I said, the triage evaluation is a very brief one. In a cat, once again, obviously, palpating the bladder would be important, and distended abdomen in a large breed dog just as important. Or a bleeding source, external bleeding source in any patient. So when do you need to triage a patient? In every single emergency patient. Every single not filed patient has to be triaged. Every routine patient that might present with unexpected problem also will require a triage, meaning a patient that is in wards or stall, as it is called in our Tischspital, that has an unexpected clinical signs and is actually a routine patient that was not expected to have such deterioration, or any patient that is hospitalized that clinically deteriorate or has developed a new problem. Triage over the phone is extremely difficult, extremely biased, and extremely unreliable. That's why triaging over the phone is largely unreliable and useless tool to either be prepared or to already decide what that patient needs. We already had over the past few days some examples of dogs that presented with life-threatening situation that then declare themselves to certainly not be such, and other scenarios of patients that were presented for very simple evaluation that turned out to be catastrophes. So the referral or even the communication over the phone with the client is certainly not a substitute for the triage exam done on arrival. Why to triage, once again, is done for the reason that we listed above. Here you see a patient that could easily present to the triage. This patient got attacked by a lawnmower. Well, kind of fell under the lawnmower. Based on the initial evaluation, this patient is an amputated patient where our attention as human being will go straight to the missing leg, and that might become the focus of our attention. What we should not miss is that there's a lot of blood on the skin of this dog, but once again, the triage has nothing to do with assessing how many legs the dog has. Nobody cares of how many legs the dog has during the triage exam. What counts in the triage exam is the fact that circulation of this dog is compromised, his mucous membrane are pale, his CRT is compromised and extremely abnormal, and the patient is tachycardic, his mentation is compromised because through that amputated leg, he bled enough to be at risk of death. So despite the fact that the most obvious thing is the fact that the dog is missing a leg, that does not represent at all a reason for classifying that patient. This mucous membrane are going to be the reason why you'll take that patient right away back in the room for further assessment and stabilization. What are we aiming for? As we said, the reasons are deciding if that patient is in a life-threatening situation and what is that life-threatening situation. The assessment is done on the cardiac assessment and perfusion, where obviously is a patient in cardiac arrest or not, the heart rate, the pulse quality, mucous membrane. Breathing is whether the patient is breathing or not, is dyspneic or is normal. The neurological status is either normal, obtunded, unconscious, or is having seizures. This degree of obtundation or abnormal mentation can be further classified, but is not the immediate need to tell whether it's stuporous versus comatose. Those are a little bit of finesses that might not be required or really establishing the urgency for that patient. Abdomen, as I said, is distended in this large breed dog. That could be representing already an urgency by itself. The bladder being turgid and painful in a cat, certainly, despite appearing on a cardiovascular, respiratory, and neurological exam normal, will represent an immediate emergency because it could certainly represent a life-threatening situation. And with this was just a repetition of what we talked about. Examples of the categories in triage patients. You're going to have a patient that has inappropriate level of consciousness, which is obviously an unconscious or a status epilepticus patient. That is a class 1 triage patient. A respiratory problem, a patient that is not breathing or in respiratory distress. A patient with abnormal gum colors that is extremely pale or white or cyanotic, gray. Patient with severe arrhythmias during auscultation. Patient with they have obvious severe hemorrhage. Or patients with specific abnormalities, like patients that were shot, patient with impalement injury, patient with large breed with abdominal distension. Those by definition are class 1 triage patients that they need to be prioritized over anything else. A class 4, as I said, is the patient that is not really an emergency. It's a patient that has vomited and had diarrhea once or twice. It's a patient that has a little lameness. It's a patient with a little abrasion or laceration. Is a patient with a broken toenail? Is a patient that has sneezed a couple of times? Or a patient that had a little bit of hematuria only just that day? They may not represent at all an emergency that will have prioritization of care over sicker patients. After the triage, what you want to do is maintain the strong communication with the client. Because once you have assessed the patient, you need to tell the client whether you have decided that their dog or cat is stable or unstable, and tell them why. If you continue that communication, if you will have them to continue the communication, especially if you decide that that patient requires a little bit more of an immediate evaluation and assessment, you want to have permission to do basic assessment and life-saving treatment. And that includes the IV catheter, IV fluid, resuscitation, and such. You want to know, especially on the unstable patient, immediately what the resuscitation code is. And back to the treatment area, you want to always have somebody that will be able to evaluate and keep an eye on that patient while you are communicating with the client. That's why ER medicine is a teamwork. It's never a single person doing it all. The major body system assessment then is a more thorough physical examination that follows the rules that you already have done during your training as veterinarians. So you're going to obviously assess the heart thoroughly and circulation thoroughly. You're going to assess perfusion in a way that is meaningful to determine the stability of the patient, if the patient is potentially in shock, and if he's compensating for shock, or if he's decompensated because of it. Lung assessment goes farther beyond just breathing normally or abnormally or not breathing. There would be a better assessment where we're going to have a rate, an effort, the pattern of breathing, and the sounds that we are hearing on auscultation. Brain assessment, as I said, the important thing in triage is normal or abnormal. And once you get to abnormal, you can differentiate the level of consciousness from coma to stupor, obtunded, dull, quiet, normal. And then seizure activity, if it was a single event, if it's a continued seizure, and so on. And you can finalize your neurological assessment with a brief neuro exam to complete your assessment. And on that note, we have completed this little brief consideration related to triage examination, and is a little bit longer than the normal presentations that I promised to post on our YouTube channel, but I want it in one piece to have all together related to triage. Please subscribe to the channel and give some feedback. We'll continue with the lectures over and over and over. Thank you very much, and bye-bye. Enjoy.